Well, welcome to our first health policy grand rounds of fall 2022-23 academic year. Yay. And we are doing an experiment for the first time ever with health policy grand rounds of having it in a hybrid format with an in-person speaker. We had the fortune of having Kevin Griffith have family in the area. And so we decided to take advantage of that to have him come and speak. So today we have Kevin Griffith, who is at Vanderbilt University, and he is also affiliated with the Boston VA. He and I first met because he was in graduate school with Carolina Herrera. For those of you who've been here for a long time, remember her as a statistician here who worked with me on a number of studies. So if you dig around in the archives, you'll find Carolina's name. Carolina introduced me to Kevin. Kevin and a colleague of his, Samantha Auti, have done research that connects and overlaps with some of my areas of interest. And so we have kept in touch over the years. So thank you for coming. Thank you for being here. The presentation is on racial disparities in wait times in U.S. healthcare delivery, and I'm focusing on specialty care. And I will, without further ado, let Kevin take it away. If you are hybrid and on the Zoom, Kat is monitoring the Zoom for questions that might come in. So you can type your questions into the Zoom. And then for people in the room, when we get to the end, you can raise your hand. If anybody has a burning question about something on a slide, may they raise their hand? Okay, so if somebody has a burning question and you're in the room, put your hand up and say, I really don't understand that slide. Can you explain that more? And if you're on Zoom and you have a burning question, type it in the Q&A and say, burning question. So maybe Kat will catch it in time. But otherwise, we're going to try to leave plenty of time at the end for Q&A. And for those of you who did not, who are interested in meeting Kevin later today, IHPS is having a happy hour on the outdoor deck at the Valley Center, 490 Illinois. So you can come by and have a alcoholic or non-alcoholic beverage with us later, and maybe Kevin will stick around for that too.
Absolutely. All right, well, thank you for that introduction, Joanna. Thanks so much for having me. This is actually only my second in-person seminar since the plague, so it's great to actually see folks in person. And thank you, Jen, for that introduction. A little bit about me for those who are unfamiliar. I took a very unusual path to public health. I actually started out working for the U.S. Army and then the Department of Defense, first doing research to support our war fighters in Iraq and Afghanistan. Questions like, how many troops do we need? How many, where should we locate our medevac units to minimize response time? But then I moved on to conduct program evaluations of mental health interventions within the Army, trying to improve psychological functioning, reduce suicidality of active duty soldiers, which of course is a very salient issue for them. And now I'm at Vanderbilt University, but I've maintained this connection to military populations and working with the VA there. So today I wanted to share some work that's currently underdeveloped that I think has pretty substantial implications for public policy, both within the VA and elsewhere. And I welcome your comments. This is a manuscript actively under development, so we can roll your feedback right into the study, of course, without attribution. And then I can't take credit for the idea behind this work. It actually belongs to Daniel Asfaw, who's a VA postdoc right now, an economics grad from Indiana University, and I believe he's actually on the market this year next, so look out for him. And then before I start, I also just want to note this project has a diverse and committed team, and I don't feel like this represents health equity tourism. I try to do my best to discuss the issues of race and racism with great care, but I also understand my positionality as a white man giving this talk, so I ask in advance for your forbearance and feedback when I don't get it right. I'm always trying to learn how to discuss these issues better. And so it's probably not a wild statement to make to this group, but the US has pretty persistent racial disparities in access to care, health services utilization, health outcomes. The Institute of Medicine commissioned this landmark report on equal treatment in 2002 that found abundant evidence supporting the relationship between societal factors, including race and health outcomes. And unfortunately, that evidence base has only grown since. So racial and ethnic minority groups throughout the US experience poorer healthcare access, higher rates of illness and death across a wide range of health conditions, including diabetes, hypertension, obesity, asthma, heart disease, when compared to their white counterparts. And many of these observed disparities are avoidable and thus unjust. So, we name and blame structural racism as a contributor to many of these health disparities, which involves the complex interplay of macro level systems, policies, as well as institutional practices and policies which accumulate over time and result in the unfair advantage of one group over the other. So examples of this are legion. For instance, New England Journal of Medicine. Any of the folks here saw this a couple weeks ago. They published an article about how doctors until like the 1960s used to believe Black people had denser bones, more muscle, and thicker skin, so they got higher doses of radiation from X-ray techs and radiologists. And then the focus of this talk today, timely access to care has been recognized as a important issue and important determinant of health and well-being by both the Institute of Medicine and the World Health Organization. Delays in care can result in unnecessary suffering, reduced treatment efficacy, increased risk of complications and death. And differences in appointment wait times could represent one potential mechanism through which structural racism affects health and health outcomes. But unfortunately, there's a blind spot here. We have lacked data on appointment wait times, at least in the United States. We have much better data in other countries. And so we know that wait times are not just an issue in the US, it's kind of an evergreen issue around the world. Excessive waiting for treatments can deteriorate patients' health status. And we believe wait time should be equitable based upon health needs. So people with the same health needs should have the same wait time without any differences due to your socioeconomic position or your racial identity. But we also know the wait times that you experience for medical care are affected by the larger policy environment. So, for example, public support for medical schools, restrictions on nurse practitioner scope of practice can affect the supply of clinicians. Structural racism can lead to differences in health literacy, insurance status, mistrust of the health system. Neighborhood segregation and poverty can lead to longer travel times and more transportation issues for non-white patients. And all of these challenges can manifest as longer wait times and disparities in wait times for medical care. But what do we know about wait times in the US? Well, it's actually, we know quite little, which is a little shocking when I first started looking at this issue. So measuring wait times for medical care in the US is really hard. It's a highly salient policy issue, but there's no publicly available data sets of wait times in the United States. Health systems know their wait times. Vanderbilt knows their wait times. UCSF knows their wait times, but those are trade secrets. They're not made available to researchers, at least external researchers, and they're not publicized. So what data we do have are usually limited to labor-intensive, secret shopper surveys. So organizations like Merritt Hawkins will call a small number of primary care practices in a small number of, usually our largest cities, and they'll ask the receptionist how long it'd take to get an appointment as a new patient. It's better than nothing, but this is not really, as an applied data researcher, this is not really the type of data I want to make bold claims about disparities in wait times or how long people wait for medical care. And so one example of this, just so what we do know, so this is from Merritt Hawkins. They called 25 physician practices in select cities throughout the country, and they asked how long they have to wait for a new appointment. And these rankings are released with much fanfare, usually covered in the national media. And hey, look, I'm a big fan of statistical sampling and asymptotics as the next applied research, but there's millions of healthcare professionals in the US, and 25 practices in a few select cities is just not that great of geographic coverage. We also have audit studies. For example, this is from a paper published in 2020 in JAMA Open, where they called 800 primary care practices. And obviously you can't see what a person looks like through the phone, but they used trained researchers to signal they were of varying races through pseudonyms and vocal inflections. And this is showing the wait time that was offered for Black callers. And then you see, compare it to white callers. I'll just flip back and forth. So white callers tended to be seen really quickly. Another finding they saw was that the receptionists, the clinic staff, quizzed or interrogated the Black callers more about their insurance status, which sort of suggests stereotype about their perceived willingness to pay. And we actually do have pretty good data on emergency department wait times, where we see that patients white patients, who are the blue bars, are seen faster than other racial groups, regardless of the trauma level of the emergency. So these are only once you actually arrive to the emergency room, how long it takes for you to get triaged and seen. But we have some suggested evidence that there might be some disparities in these wait times. And so we have, what I'm going to talk about here is we have a novel data set on these wait times that comes from the VA, but we actually have millions of appointment records for non-VA providers. And we actually are making it public. So you can actually go online. I'll show you how today. If you're interested in this data, you could download it right now while I'm talking, without restriction or cost. So a little bit about the VA, because that's where this all comes from. The VA is basically our example of single payer in the US, provides care to more than 9 million veterans and their families. There's about 141 medical centers and a bunch more affiliated outpatient clinics. One nice thing about working with the VA is the data comes in near real time. So tomorrow I can see what was recorded in EHR today. We have access to not just what was done, but we can see outcomes of care as well. So we get into test results, clinical outcomes. That's a curse at times because this is the federal government. They kind of underinvest in data infrastructure. Every single data pull takes a really, really long time. I've gotten a few very angry emails from the people that run the servers. But historically, most of the referrals to medical care are completed within the VA system. The VA has had what's called fee care, where they pay for a small number of veterans in very select instances to be seen by non-VA providers. But prior to 2014, this wasn't common. I'll just give you an example for those, again, unfamiliar with the VA. They're scattered throughout the country, their medical centers, but they're generally all in the populated areas. There's one right here in San Francisco. There's one co-located with Vanderbilt University. And so in 2014, something happened. You guys might remember, I don't know who remembers the Phoenix, the VA waitlist scandal. Oh man, okay, I'm interested to see this kind of faded from memory a little bit. I wasn't even working for the VA, I was working for the Army at the time. So we were paying attention to this. But in 2014, the VA was embroiled in a massive scandal over wait times that veterans experience for care, particularly at their medical center in Phoenix, but it was not limited to that one. The leaders of these medical centers were performance managed. They got pay bonuses if wait times were below certain thresholds. But the medical centers were not resourced nearly well enough to meet these thresholds. They still aren't. So officials at the Phoenix VA were accused of having the official wait list that they reported to the public, reported to Congress. Then they had the shadow wait list, which was how long it actually took people to seek care. It was kept out of sight of federal regulators. Interestingly, one of my PhD mentors was James Burgess. He actually noted this. He's since passed away, unfortunately, but he actually noted this in a research report years prior, but it kind of went ignored. But eventually there was a whistleblower, led to a VA audit, a media circus, and then you also saw Congress. They were hauling VA leaders before Congress. So this led to greater oversight of the VA's operations. And it also led to a couple really big pieces of public policy. So Congress took swift action in the scandal's wake. This first piece, which was passed the same year the scandal broke, was the Veterans Access, Choice, and Accountability Act, often just called the Choice Act. It was signed by President Obama, and this instituted the Veterans Choice Program, where enrolled veterans were allowed to seek care in their communities at VA expense if they lived more than 40 miles from a VA medical center, or if the VA facility was unable to offer an appointment within 30 days. Approximately 2 million veterans received care from community-based physicians under this program. And then, of course, the military and VA loves acronyms. And I'm really curious how long it took them to think of this one. And they were probably very proud of it. But they passed the Maintaining Internal Systems and Strengthening Integrated Outside Networks, or MISSION Act of 2018. This was signed by President Trump. And this further liberalized their access to community care at VA expense. So now, as of 2018, if their drive time is greater than 1 hour, or if you're unable to receive a primary care appointment within 20 days, or other specialty care within 28 days, you could be seen by a private sector provider for free, or the VA will cover it. And about 2.7 million veterans and counting have now used private sector providers as a result of this. So each year, the VA pays for millions of appointments with hundreds of thousands of veterans. They've established contracts with Optum and TriWest healthcare alliance to provide care using their existing networks. These networks have about 1 million clinicians as part of them. Just an additional background, they're typically reimbursed at Medicare rates. So if you're seen outside the VA under this program, you just get whatever the Medicare rate would be. And then the VA enforces network adequacy standards to ensure sufficient geographic coverage of both primary and specialty care within this network. And so you might wonder, sort of, how representative are these community care networks? Well, this chart and the next work are from a separate paper where we're trying to answer that question. So we grabbed NPIs for every physician that saw a veteran under the community care program. We summed them up to get the number of unique NPIs per state. And for the denominator, we took data from Medicare for all NPIs with a claim attached during our study period. And there's substantial regional heterogeneity, but even the lowest states, about 28% of all participating Medicare providers were part of this community care network, and it gets as good as 70%. Generally, it seems to go by the more rural areas, maybe where there's less healthcare access. They probably had to contract with a larger share of the physicians in that area. That's why you see New England, especially New Hampshire and Maine, or the Great Plains, a very high penetration here. And it also varies a good bit by specialty. So some specialties like cardiology include the large majority of providers that see Medicare patients. Others, especially services that are very well covered by the VA, such as audiology and mental health, have a lower share. And one thing we do know that the veterans that seek care from these providers probably have little different patterns than the general population. We believe that the wait times we see for the private sector are probably highly correlated with the general population's wait times. That's work that we're also doing. I'm working with Engi Zaiden at Tulane. She has access to that trade secret data on private sector wait times across the country. So she can give them me, but I can give her mine. And so we're going to see how well they actually correlate. So in this study, and what I want to talk to you guys about today, we use some of these data to look at wait times for VA and non-VA specialists. And then we looked at whether those differed by race. And then we actually go a step further and try to start identifying why. What are the drivers of these potential disparities? And again, we provide our data sets as a public service, and just so you can use them in your own research. And so where did the data come from? I mentioned the VA. The VA has these really robust data holdings. The corporate data warehouse has a record for every referral to specialty care, regardless of whether or not they were seen at a VA or a community medical center. Community care clinicians have to submit their appointment data as part of their claim. If they ever want to get paid, which they usually do, they have to provide records to the VA on when they actually saw the patients. So we pulled all consult requests. So these are referrals to new patient relationships, referrals to new providers, new clinical relationships between 2018 and 2019. Why not more recently? We have the data, but we all know why. Didn't want to mess with 2020 and 2021 data quite yet. In total, our data include about 11.3 million consult requests for both primary and specialty care. The overwhelming majority of primary care is handled within the VA. So I don't show that here, but if you're curious, that is in the data as well. And I'm happy to share these after, but we also published a data brief that explains in gooey detail, more than you ever want to know, about how these data sets were generated. It's part of a Mendeley data repository. And so we have 4 de-identified data sets where you can get wait times at a facility level if you want VA specific wait times. You can see by county, zip 3, even individual level, although we had to do some further de-identification. You can only get year instead of year and month. You can't get county. But those are all just hanging out online. So we have 4 outcomes in the data. The one we focus on is this difference between when the appointment was approved and when the appointment was actually completed. So these are timestamp dates. We actually see the exact date and time in the record. Once a consult request is initiated, usually there's a short 2 or 3 day delay before the local VA medical center approves the referral. This is especially, and it's a couple days longer for community care appointments versus in-house. They have to make sure the veteran's actually eligible. So we exclude that from our analysis because otherwise it's kind of an unfair comparison of the VA versus the private sector. It artificially makes the private sector look longer. You could also see if you want to how long it takes for an appointment to get scheduled, or the total wait time. That's all in there. But anything I show you today is all about this days to completed measure. So it's the difference between when it was approved and when the patient was actually seen. And for race and ethnicity, we have 5 groupings. You're non-Hispanic white, non-Hispanic Asian Pacific Islander, non-Hispanic Black or African American, non-Hispanic American Indian, Alaska Native, and Hispanic or Latino. We would have loved to go more granular in this. I recognize these groupings are common, but they mask substantial within group heterogeneity. For example, Korean versus Filipino Americans. Our lead author, Daniel, emigrated from Ethiopia. His experience are vastly different from a Black patient emigrated from Haiti. The data are there, so we do have them if folks want to look at them. But the sample sizes, you get pretty small sample sizes pretty quickly. And of course, since this is a research project about disparities, white veterans are the reference group. And so our analysis proceeded in 4 steps, and I'm going to simplify here because I'm sure most are interested in our results rather than our fancy econometrics. But first, to illuminate disparities in access, we calculated mean wait times stratified by race, ethnicity, and whether the appointment was for VA or non-VA. And then second, we estimated a bunch of multivariate regression models. So the wait time is the outcome. Our predictors included individual and referral level characteristics, so age, gender, specialty. We estimate these separately for each racial group and care setting. So for instance, we could see whether the effects of increasing age or increasing number of comorbidities, if that relationship with wait times differed between Black and white patients. And the covariates we included, it was age group, documented sex, priority status, which is a measure of income and service-connected disability that the VA uses for eligibility determinations. We had referring specialty, your Elix-Hauser comorbidities, calendar month and year. And then we used Oaxaca blinder decomposition to identify sources of racial disparities in wait times. So who has used or heard Oaxaca blinder? Probably the economists in the room. Yes, okay. This was originally developed in the 1970s to explore discrimination in the labor market. But it's since been applied to a wide variety of settings, including inequalities in health outcomes. So the first thing you do is for your baseline group, you'll estimate a regression. Here we have our wait time, and we have all these individual and referral level predictors. We'll also estimate it for our comparison groups. This could be one for, say, Black patients. And so the covariate levels will differ. There'll be a different age distribution, different specialty mix, but also we allow these coefficients, the effects of those can differ for each group. And then we can actually decompose the differences. So we can see, for example, here, the difference between white and Black patients is going to be the differences that are due to differences in your covariate levels, but also differences in those betas, those regression coefficients, and then the interaction between the two. So this first, I don't know if you guys can see my mouse on there? Yes. So this first term is actually what's called the endowment effect. And this is the portion of the disparity that is attributable to differences in observed characteristics. So if you had, for example, if older veterans tended to get shorter wait times, and maybe the population distribution was less favorable in terms of age for Black versus white veterans, this will tell you how much of the disparity you observe is due to differences in the age distribution. This next bit is, this is called the coefficient effect. This is the portion of disparity that's due to those differences in group level associations, so the betas from the regression that you estimate. And then the last is the interaction effect. This is the portion of disparity that's due to the simultaneous effect of different covariate levels and different associations between those covariates and wait times. And I have, look, I had little things I added for this talk. I was pointing at them. Try so hard, Kevin. Okay. So that we see those three big buckets, but then we also can drill down even further, see, okay, what is the effect of age? What is the effect of specialty mix? So we could see what are the potential drivers of these observed disparities. And so first, a nice boring table on veteran characteristics. We'd see there's not actually wild differences across the races in terms of the characteristics in here. Fairly similar age distributions. The black population tends to be younger than the white population or other ethnic groups. Comorbidities, these are the count of your Ehlers-Danlos comorbidities, so it ranges from 0 to 31, and that's just showing the average. There's not a wild amount of difference here. For those priority groups, for those who are not steeped in the VA nomenclature, priority groups 1 and 4 are those with serious service-connected disabilities. Groups 2, 3, and 6 are those with low or moderate service-connected disabilities. Group 5 are people with economic hardships. Group 7 or 8 have no service-connected disabilities and household incomes above certain thresholds. If you're in group 8, I think you might have to pay some copays to use the VA. So compared to white veterans, non-white veterans are more likely to be female, younger, more likely to be in a priority group associated with low income or serious service-connected disabilities. And then Black veterans tended to have the highest burden of comorbidities. And so overall, this is not adjusted for any differences in specialty or age and so on. But overall, veterans waited just under 31 days for specialty care. White veterans had the shortest wait time on average, while Asian and Pacific Islander veterans experienced the longest wait time, 32.1 days. For VA referrals, Hispanic veterans had the longest mean wait times, followed by Asian Pacific Islanders, Native Americans, and finally white veterans. For community care referrals, Black veterans actually had the longest wait times, followed by Asian Pacific Islander, Native American, then white veterans. Hispanic veterans actually had the shortest wait times for community care of any group, which was not expected, to be honest. And I'll note here, the media does a profoundly terrible job at communicating these kind of top line results. For example, most people, I think, would believe that the VA takes longer to see patients than the private sector, but not just here, but also, again, we see here the VA's wait time for overall and for every group is substantially lower. We've seen this multiple times and throughout our research. The VA actually tends to see people faster than the private sector, and regardless of your race. And descriptively, we see these differences are driven by people in the tails of the wait time distribution. So the way to read these charts, left panel's VA, right panel's community care. 0, that's the normalizing this to the wait times that white veterans experienced. So we see down at these wait time deciles, in the lower deciles, there's very small differences between white veterans and non-white veterans. Then this kind of rises and tails, especially for community care. For example, this black line is not intentional, it's Black veterans. You see, once you start getting in the 6th, 7th, 8th, 9th decile, the wait times that Black veterans experience are just pretty dramatically longer than white veterans. So these disparities seem to be driven by people in the tails of the wait time distributions. And I can't remember who originally came up with that, but it's referred to as tail people, which I kind of liked. And so this table displays the differences in wait times in days between white and non-white veterans after adjusting for differences in specialty mix, age distribution, et cetera, and stratified by site of care. So again, the endowment effects, that's your differences due to covariate levels. The coefficient effects, that's due to differential associations between the covariates and wait times, and then the interaction between the two. So you see the largest disparity is in community care, where Black veterans tend to wait about 4.1 days longer than white veterans. And for most of these, the differences seem to be driven by endowments, that white veterans just have a more favorable mix of covariates, whether that's specialties, whether that's more favorable age distribution, that is getting them seen faster. And on the next few slides, I'll show you specifically which endowments are driving that. So here, I'm just showing the decomposition of the wait times, or of the Oaxaca blinder. So your y-axis is the difference between white veterans and other racial ethnic groups. And what first showing, these are the differences due to demographics. So very, very small. So this is age, what's in here? Age, priority group, comorbidities. These are not accounting for very much of the disparity at all, at least within the VA. And then if we add in specialty mix, that adds some. We see that compared to whites, at least Asian, Black, and Hispanic veterans tend to be making it, they have a specialty mix that's unfavorable. They have a greater number of appointments that just have longer wait times in general. But what really is driving it is place. We see that whether this is due to just chance of where people choose to live, or structural racism and chronic underinvestment in facilities that disproportionately serve non-white patients, we see that most of the disparity within the VA is due to this referring facility. So it's where you're being seen. So for non-white veterans, they just tend to go to VA facilities that just have longer wait times in general. And that's really driving the disparities that we observe. And this kind of comports with some other work. I have to look at who's from, but looking at disparities in healthcare quality between white and non-white patients. For example, if you look at heart attack mortality, Black patients just tend to go to hospitals that have higher mortality following AMI than white patients. And this again is perhaps probably due to structural racism and just underinvestment, but it's just that the patterns of care is partially driving these disparities that we observe. And then this is for community care appointments. So when we're sending folks out, again, we're seeing the demographics and your comorbidities having a very small effect on your wait times. And then if we add in specialty mix, we see, at least for community care, the specialty mix is actually a favorable in effect for non-white veterans. That at least for what the VA is sending people out to the community for, white veterans tend to be sent out for specialties that have longer wait times in general. So specialty mix is certainly not driving the disparity. In fact, it's helping, at least on the community care side. But again, at least for Hispanic veterans, it's place. So we see that, and these disparities are larger. See the scale for VA goes up to 3, it's 4 here, so it's larger disparities. But especially for Black veterans, these disparities are just driven by where you go. So it's where you live is determining your wait time. And so some limits with this, and I'll go into some of the policy implications. So this is of course observational. I can identify characteristics that are associated with these long wait times, but I can't identify the specific mechanisms through which, for example, race or age or comorbidities affect wait times. We also, with our data, we can't identify clinical implications of treatment delays. So potentially you could, if you added in some of the health outcomes data, and we might look at that in the future, or probably other folks will before we get a chance to. You can actually see, okay, if you have these longer these delays in care, especially for people in the tails of the wait time distribution, is that leading to poorer health outcomes? So likely yes, but we don't have data on that yet. And then at least for hopefully once Engi and I get around to comparing the community care wait times with just general private sector wait times, we'll be able to say how well these wait times might generalize. I would argue though, for now, these data are definitely our best estimate of private sector wait times in the United States, because beyond this, it is those secret shopper surveys in like Boston and New York and San Francisco. And then of course, with the community care network, I tried to show you some data on how representative the network of providers that see these patients are. even in states that have low penetration, still these community care networks include almost 28% or more of all eligible Medicare physicians. So they're probably pretty representative. And so getting into policy implications, the first, the stated act or stated mission of these goals was to lower wait times for veterans by increasing their access to private sector care. However, these programs have not been without significant controversy. Right? If you are having people, you have this cross-system use, you're encouraging cross-system use between the VA and non-VA physicians, you get care fragmentation. You also are sending folks out to physicians that perhaps lack a deep understanding of military culture. Obviously, if the VA is cheap, you send them out to private sector providers that costs a lot of money. The VA spent $22 billion last year on the community care program. And then when you send someone, it also causes cascades of care. So you send someone out to a private sector provider, they get referred and get a bunch of tests and treatments in the private sector. And the VA doesn't have a system yet to try to recapture those patients. I know, like with Kaiser, if Kaiser sends someone outside the network, they have teams of people that are their goal is to get them back. The VA doesn't have that yet. And now we're adding two more things to this pile of evidence against the community care program. One is that you wait longer on average. And then you have these larger racial disparities in the private sector compared to the VA. So this is kind of contrary to the entire purpose, at least stated purpose, of the Veterans Choice Program or the Mission Act. We also see that the bulk of these disparities were place-based. So compared to white veterans, racial and ethnic minorities were disproportionately referred to facilities where mean wait times were longer. So this could reflect structural racism, both in where healthcare providers choose to practice or chronic underinvestment in healthcare infrastructure for veterans who belong to these minoritized communities. Our findings that our studies finding that most of the disparities in wait time are driven by differences in where you reside and thus seek care implies policies to increase quality and capacity of the healthcare supply in under-resourced areas might be promising. For example, on the private sector side, you could have better and longer incentives for doctors to relocate in underserved areas. The existing evidence we have suggests that doctors who are incentivized by policy to practice in these areas often won't stay once those incentives run out. Another thing, it just seems like very low-hanging fruit to me, is reporting requirements would be a nice start. So even if only aggregate data are made available to the public, if health systems, what gets measured gets done. If health systems have to report aggregate wait times by race, that could increase their focus on it. We could also add wait times to the federal government's definitions of healthcare professional shortage areas. Wait times is arguably a more direct measure of patient access than simply looking at the number of physicians in an area. And then on the VA side, we first want to make sure that the longer wait times we observed at VA medical centers are not due to, or at certain VA medical centers are not due to a lack of staff resources versus issues with productivity. There's work actively going on in this area. My money is definitely on the latter. Congress often tries to push the VA to do more with less. Everyone, representatives and senators carp about, we need to support our veterans, but then the funding actually isn't there to hire enough physicians to meet the demand. They're told to sort of squeeze more productivity with limited resources. I don't think there's a whole lot more squeezing that can be done, is my sense. So instead, you could add slots, you could add FTEs, have higher recruitment and retention incentives to encourage physicians to work for the VA and to stay with the VA. You could also have greater investment in mobile medical teams. For example, the VA Clinical Resource Hub initiative, so marshals resources towards veterans in areas that are underserved for either primary mental health or specialty care. With these hubs, this program is fairly small. These hubs could be more adequately resourced and promoted as a mechanism to reduce racial and ethnic disparities and wait times, either through telehealth or in-person care. So relocating them to, you're doing hotspotting and relocating them to areas that you're seeing flare-ups in terms of wait times. And with that, I think I'm just about at 45-ish minutes of doing, so I will stop and take your questions. Thank you for your attention. Yeah.
So great presentation, super interesting stuff. And I imagine the answer to this is going to be this is the next paper. But my curiosity when you said that some of your policy takeaways are is community care effective? Do you have historical data of wait times prior to the various expansions of community care? Can you like do the basic iterative time series or look at patients who did or did not leave for the diff and diff or something like that?
You can see it on the VA side.
Okay.
And so there is a we have a JAMA open paper that looked at the top 4 of the top specialties in terms of volume. The data are there to look at all other types of specialties prior to the implementation. What we saw is we didn't see that implementation of the Veterans Choice Program or the Mission Act lowered at least the VA wait times. We can't actually see any effect on community care wait times prior to 2014 because while there's some data, it was a very strange, like non-representative population that was sent out from the VA before that. Yeah, at least we have not seen evidence that this really led to it. There's another paper, if I'm going to plug somewhere, came out last month. Evgeny Feynman at Boston University led it, that compared by region VA versus non-VA wait times. And we found that for most VA, the overwhelming majority of VA regions, wait times were shorter for primary care, mental health, and all other specialties compared to the private sector. So it kind of suggests, and this is further evidence that this liberalization of access might work for some veterans, but probably not most veterans or in most areas where they live. Yeah.
Great talk and very interesting topic. I'm wondering how was the race or ethnicity transmitted to the people that were making the schedules?
Yeah, so for this, for the community care provider, for the VA, obviously you're there, they know your race. For the community care, there's 2 mechanisms to make the appointments. One is the veteran actually goes out and makes it themselves. I think this is the dominant modality. So then, just like in prior work, they see your name, they hear your vocal inflections, and people, when you're calling someone, they make an assumption about your race. The one sort of for some portion, usually folks that are sicker, sometimes the VA medical center will actually make the appointment for you. And so that would kind of in some sense bias our effect towards the null. This, like, for example, if you have a patient with like dementia, you're not going to be like, good luck, here's a list of community care physicians, make your own appointments. You're either going to give it to their caregiver or you're going to, the VA centers will make it for them. Yeah.
Julia, I was wondering if you had any metrics as to quality of care and or satisfaction.
With
The difference between the VA and the private sector.
Yes, this is another issue where I'm going to soapbox for a little bit. I am not a VA stan. Like if the VA was doing terribly, I would publish that and it'd probably get more research attention. Yeah. To be perfectly honest. But the VA veterans tend to be really satisfied with their care. It's actually kind of annoying when I'm trying to use veteran satisfaction data because it's all like top coded. Like everyone gives them like a 9 or 10 out of 10. So I can't see any variation. And this is something that also comes as a surprise to folks, because it's thinking about the media coverage of this. An error in the VA is public knowledge. It's reported to Congress, comes national news. I'm going to say if it's Vanderbilt screws something up, you can just kind of cover that up, sign some non-disclosure agreements, and so it sort of leads to this public perception. There are efforts underway to sort of compare health outcomes between community care and VA. It's still in its early phase. From what I've been privy to, it seems like we're not finding differences in health outcomes. We are finding increases in wasteful care, for example, wasteful medical imaging, and it just costs a lot more. Which again gets to why are we doing this if we're not actually seeing patients faster and it's just draining the VA's budget? Why is this part of our public policy? Yeah.
2 things. We just had someone ask if you could please repeat the questions for our
right.
And then I have another question on Zoom.
Does this work? If you want to try. I don't know. It's sitting up here.
The ceiling mic's on.
Oh, okay.
Okay, so question from Zoom from Brandon Yang. Hi, I'm a medical student at UCSF with cardiology clinic at the San Francisco VA. The effect size of the referring facility is striking. In my experience, follow-up from the referring provider advocating for faster consultation often makes for a big difference, i.e. nagging in wait time. Though difficult to measure, it would help delimitate if there are differences in referring provider actions by the race of their patients. Curious about how you think this might be studied.
Yeah, it's an interesting question. So I don't know, again, I'll repeat it, but you let me know if folks on Zoom can hear that. Is it basically that your physicians can, be your advocate by nagging, and if they say, hey, you still haven't gotten this person scheduled, like, can we get them on the books? That might cause it to be seen faster. Sort of how might we see the effects of that? So within the VA, I'm not sure if they're actually like, if I know that like notes, I avoid notes like the plague. I don't know if anyone's worked with notes data, but it is really difficult to parse and do that text analysis. Like, God bless you if that's what your research is on. We have it. So I imagine you could see some of those notes, but also you could probably just look at, does the time it takes for an appointment to get scheduled differ? You could sort of look at provider level effects. So if you think some providers are doing a really good job of this, are their patients, after controlling for all the things we control for, are they actually being seen faster? That'd be the way I would approach it. I think it certainly can be done. The data are there. And I think you were first now.
Okay, so so full disclosure, many years ago, I worked for the Senate Veterans Affairs Committee. And so
Ooh,
I
okay.
actually had to pay attention to where VA facilities are located. And as your map shows, it's not uniform, nor is the distribution of people in this country by race ethnicity. So my question, and maybe this is the next paper, is whether you looked at this kind of regionally or state-wise to see is some of what's going on that we just have less capacity on the ground, whether it's VA or not VA, in some of these places where we know we have high concentrations of Blacks, Hispanics, or Asians.
Yeah, absolutely. We have so we have, I don't show it here, but with the decomp, just because it's a lot of rows, we can actually see the effect for each VA facility, like whether you're sent to this one or this one. We could also see how that effect might differ by race. So I mentioned in general, there is some small, but there are some racial differences like within facility you're sent to. It's very small, at least it's within the VA. For example, white patients are seen slightly faster. But yeah, I think that's absolutely the story that comes when you look at it, is that the VA's funding, like the way they fund their different medical centers, there's a lot of inertia built in the model, and that the historical funding and the FTEs go to these facilities that are in just whiter parts of the country.
Rural West Virginia, rural New York. They're not necessarily going to Arizona, which has A, lots of older people, and B, lots of Latinos.
Right. Absolutely. Yeah.
Another question from Zoom from Naomi Bardock. The blinder Oaxaca, Oaxaca. Okay.
And if you really want to know, you'd be like, oh well, Kitagawa discovered it separately, so you could sound like really annoying at parties and be like, it's actually Kitagawa Oaxaca blinder decomposition. But,
Yeah.
This is where people walk away from the cocktail party.
yes.
Is an interesting method that I haven't seen before. Do you know if it can be done in Stata, and how did you decide to use this method as opposed to any other method? Do you have any good reference points or references to point to? Thank you.
Absolutely. Yeah, I think I would say probably Stata. It's probably done much more commonly in Stata because that's I'm an R person, but I'm an appreciator. I'm open-minded, but most economists use Stata. So I'd say that is. And I'm sorry. Do I need to repeat the question? Or could they hear it?
Yeah, you can tell Naomi to come and bug me. I'm trained as a labor economist.
Yeah.
So one of the highlights of my job market was meeting Oaxaca. It was so exciting to meet him.
Yeah.
Yeah, it's a dude. It's a dude. Yeah, from Arizona.
Oh yeah. It's the question, in case Zoomland couldn't hear it, was are there resources to do this, the Oaxaca blinder decomposition in Stata, and then are there some good citations getting started in it? Yeah, there actually are. I mean, say Stata is definitely perhaps the most common program with which this is done, but there are packages in R and there's packages in Stata to do it. There are nice. I mean, some of the. Gosh, as someone who can read the economics articles, I don't want to. there's a lot of math. But if you, I have citations. There are some very great. I can't just speak them out, but if you contact me, I'm happy to send some to you. Or I'm assume normality on Twitter because I'm a giant nerd. But
It has a Wikipedia page
Ah.
that calls it the Kitagawa blind or
Yep.
Oaxaca decomposition.
Yep.
That's awesome.
Yeah, sociologists actually discovered it at the same time. But there are some lay example like write-ups that I think are really accessible within the health literature now that I can send you. So you don't have to go through the sufferfest that is reading an article in the American Economic Review or something.
I think there's a Stated Journal article on how to use
Okay.
the user-made Oaxaca command too.
Yeah.
So,
Perfect.
It's really
Perfect.
easy. It's actually surprisingly easy to implement, even though it
Yes.
looks complicated in the equation.
Absolutely. What are the questions you folks have? Yeah.
Yeah, my question is kind of related to your question, and with the assumption that, always when you assume you have a chance of error, but with the Hispanic population gravitating to certain facilities, are they, clearly there's differences in facilities, and historically, in a larger healthcare system, there's different cultures within each facility that contribute to the way the care is delivered. Are they looking at the differences between the facilities and seeing what they can do about it to improve it, like, metrics and metrics?
Yeah. At least for wait times, not yet. So this is all very new. Even being able to, so we actually wrote the code 2 or 3 years ago to even calculate these wait times because it just hadn't been done before. Sort of VA facilities had a general kind of idea of how long it was taking to see people. So we are in this first stage of trying, I'm actually meeting with the VA central office on Friday to talk about some of the stuff. So we're in the stage where we're trying to make leadership and perhaps even Congress aware of these data and what they're showing. Because we think it should be something that is performance managed and is probably a much better measure of access than they're using previously. And obviously, why we don't show it here. And our goal, my goal one is not to, maybe within the VA, we might name and shame specific VA facilities so that folks can do a deep dive and see what's going on at X medical center where they have this big disparity. I think that's the goal. Absolutely. Yeah.
The difference in Hispanic wait times between VA and community care was very striking. And I think if I was reading the results correctly, it came down to the endowment difference, suggesting that maybe there's just a big compositional difference between Hispanics seen in the VA versus community care. But I wondered if you could give us some takeaways or how you think about that really striking difference.
So looking at the VA, so this is going back to the decomposition for the VA, and the question is what can we try to, or what might be driving the pretty stark differences in wait times that Hispanic veterans see within the VA versus not VA. So this is for the decomposition for the VA. We see that there are some effects of specialty mix that for Hispanic veterans, they're being disproportionately being referred to specialties that just have longer wait times, at least compared to the white veterans. But really the effect of place is in the negative or the bad direction. It's leading to increased wait time. So that you think about where Hispanic veterans live in the country, same with Southeast, disproportionately Southeast, Southwest, those VA medical centers just have longer wait times. But this is actually the opposite in the private sector. So that for the private sector, those parts of the country are actually have shorter wait times. So for example, if you're at a medical center in the Southwest and Southeast, if you're being sent out, Hispanics are benefiting in that way. They're actually getting a shorter wait time than because white veterans tend to live in areas of the country with longer private sector wait times. So this is again that sort of the resourcing question with the VA that at least for some of these, for example, for Hispanic veterans, this disparity can't be blamed on the the VA just reflects the private sector. Right. So there's a pretty stark difference where the VA centers just have longer wait times than the private sector in those areas. Yeah.
So you were, I guess, a little bit dismissive of the role that the community care clinics are playing, and I imagine that they're sort of relieving some of the capacity constraints in the VA, and that without them, that the wait times would have been much longer there. And I'm wondering what your thoughts on that are, as well as, you know, if you can look at, say, variation in the number of these clinics, sort of the size of the network or something like that expands or shrinks in different areas, use that sort of variation to see to what extent that is having an impact on the VA's wait times.
Yeah, it's a good question. You sort of you would think that the VA sending a bunch of people out would lower wait times because you're reducing demand for VA appointments. But that also the flip side is that it does come with also reductions in the funding for VA medical care. So I mentioned the VA program, they're spending $22 billion on this program per year. That doesn't even include the cost of administering the program. So it's sort of any potential time savings from being sent out to the community care. You know, you're not holding the VA supply of appointment slots constant. So you're actually perhaps you're taking money away from those VA medical centers, which if I'm being, you know, some folks want to privatize the VA. That could be part of the, you know, sort of the not so hidden intent behind some of this. Yeah, so I think that might explain why. Because if we held the VA's funding constant and then sent people out, you would think, yeah, it would lead to shorter wait times. That's not the case. And was there a second part of that question? Or did I?
I was just wondering to the extent to which there are those sort of like interaction effects. You could look at this.
Oh, you had a network question about the networks. Yeah, so one thing this is something I am just starting to get into with I showed you a couple slides on the penetration of the VA networks and like how many of different types of specialties. This is something that I was kind of shocked. It seems very low hanging fruit that we very poorly understand these community care networks. We know that they're provided by Optum and TriWest, and they have these very broad networks. But there hasn't really been research yet on what's the effects of like these networks changing over time. So that's something there's other groups that are more dedicated to looking at like network adequacy within the VA. But we are doing some of this basic like foundational work, be like who's participating, what type of physicians are choosing the see veterans versus not, for example. So yeah, hopefully we'll eventually know the answer to that, because I think you would absolutely expect it to have an effect, that with a broader network, you should see a larger effect than a narrower one.